Hello, everyone, and thank you for joining us today. We're not quite to the top of the hour, so I'm going to allow, 30 seconds or so for everybody to join us from the lobby, and then we'll get started. All right, it's 1 o'clock. I'll go ahead and kick us off today. Thank you, everyone, for joining us for the Rural Health Executive Educational Series. I am Cody Smith, the Director of Rural Partnerships and Leadership Development at NRHA Service Corporation, and I am thrilled to be your moderator today. Before we dive in, a couple things to know. This session is being recorded, and you'll receive an email with a recording later today, I hope. If not, it'll be there by tomorrow afternoon. You'll have access to all the key points and insights from today's session, so you won't have to worry about trying to capture everything today. But at the end of the session, we do ask for your feedback through a short survey. Your input really does help us make these sessions as relevant and useful as possible for you and your peers. Now let's quickly cover a few housekeeping items. All attendees are muted to keep things running smoothly. We do have, hope the presentation will go around 45 minutes, sometimes a little under, sometimes a little over, but we do allow time at the end for a question and answer session. If you have a question, don't wait. Go ahead and drop it into that question section of your GoToWebinar control panel as it comes to mind. This is your chance to ask our experts and get advice tailored to your needs as rural healthcare leaders. Today, we're fortunate to have two exceptional speakers with us, Christy M. Bishop and Carla Brock-Wilbur, both of whom bring extensive experience in helping rural healthcare organizations thrive. Christy is a former chief nursing officer who has led clinical and quality improvement initiatives for rural hospitals and health centers, helping them achieve survey readiness and enhance patient care. And Carla has partnered with rural hospitals and health systems for years, driving quality improvement and process optimization through lean methodologies to address unique challenges in rural healthcare. Today, they'll share their expertise in a presentation titled How to Build Your Survey Readiness Toolbox, and you'll gain strategies to tackle compliance challenges, improve patient outcomes, and enhance your organization's overall performance. Before I turn it over, a big thank you to Stroudwater Associates, our platinum partner and a cornerstone of our partnership program. Their unwavering commitment to advocacy and their depth of expertise and dedication to advancing rural healthcare really make them an invaluable part of our efforts to support rural communities. We're truly grateful for their ongoing contributions and collaboration. So with that, let's get started. Carla, I'll turn it over to you.
Thank you, Cody, and thank you all for joining us today for our webinar. Again, this is Survey Readiness, Building Your Toolbox, and we are so grateful that you're here with us. So our objectives for today is we will define survey readiness, review some of the types of surveys. Some of you guys may be familiar with those, but it's always great to review them as we're talking about being prepared for survey. Another thing that is really important for us to discuss is to understand how your surveyor is preparing. So the surveyor and surveyors that are coming to your facility, they do a lot of preparation prior to their visit. So really understanding how they prepare can help you also prepare. Review state and regional 2567 survey deficiency data. And that's a great thing to do as well, to get prepared, to understand. And this is publicly available data that you can review for your state, for your region, to see, what are the top things that are really standing out now during the surveys. And then some different steps in really building your survey readiness toolbox. So those are our objectives for today. So our definition of survey readiness is to achieving and maintaining an ongoing prepared state in which an organization can confidently ensure compliance with regulatory requirements, patient safety, and quality standards. So a lot of our rural hospitals don't have a system representative to really drive that that survey preparation and survey readiness so that they can be in that prepared state. So it's kind of up to them to independently understand all of the different tactics that they can use and action plans they can design to maintain that prepared state. Why is readiness important? Well, we know that we have a large majority of Medicare beneficiaries. The latest data as of June that I was able to find, there were 67.5 million Medicare enrollees. And what that means to us as those hospitals who do count on Medicare and Medicaid reimbursement, it's very financially important for us to maintain our good preparation for survey so that we don't risk losing our Medicare and Medicaid reimbursement status. So it's very important for the health and safety of our patients, caregivers, and staff, and also very important due to financial consequences that we maintain survey readiness. It's estimated that there will be around 80 million Medicare beneficiaries by 2030. So, of course, Medicare beneficiaries are growing in leaps and bounds with the baby boomers. So it's something that we'll see more and more of as our patient population, which does impact our reimbursement. So the types of critical access surveys, and actually this is not just for CAUSE, but any rural surveys for that matter, there are certification surveys, and we'll talk about all of these: validation surveys, revisit surveys, and complaint surveys. That's the one you definitely don't want to have at your organization. So certification surveys include both the initial certification and a recertification. Those are the surveys that CMS describes as being the surveys where they pull information and glean information from the survey to see if you, this prospective or current participant in Medicare and Medicaid, meets all of the applicable requirements for participation. And so those are your conditions of participation, and they evaluate your performance and how effective you are in the Medicare participants' care. So they, that's their goal, is to determine whether or not you meet all of those requirements. So the validation survey is a survey that CMS uses to really validate the performance of a accrediting organization. So at this time, there are 4 approved CMS accrediting organizations for critical access hospitals specifically, and I think these are the same for other rural hospitals, which would be ACHC, which we don't see a lot of our hospitals that are accredited through them. Joint Commission, which is a very popular accrediting organization. The Center for Improvement in Healthcare Quality. We don't see a lot of our hospitals that use that as an accrediting organization. And then more and more, we are seeing our rural hospitals utilize DNV. So those are the accrediting organizations. One of the recent, I say recent, but it was in February, there was an announcement through CMS that they proposed a real strengthening of the oversight from CMS of these accrediting organizations. And specifically, they really wanted to hold the accrediting organizations accountable to the same standards as the state survey agencies, which was the original intention, and make sure that those accrediting organizations remain independent reviewers, make sure that they can prevent the accrediting organization's conflicts of interest, addressing any type of conflict of interest that they may have, for CMS to monitor and prevent that. Also improving the accrediting organization's performance. CMS has found that they, in several instances, that they did not really approve of what the accrediting organization was doing and finding during validation, during the certification and recertification surveys. So all of that to say, it has really put a lot more emphasis on CMS to come in with your accrediting organization, or at close to the same time as the accrediting organization. They just want to be able to validate that the accrediting organization is actually doing what they say to CMS that they will do, so that we are on the same playing field. So CMS does select providers or suppliers for validation surveys on a random basis as well. So that's important to note. A revisit survey can be where the surveyors come in to either reevaluate a specific deficiency area that they may have found when they came for your regular, your certification survey or recertification survey. Or, it can be that they revisit when they have had a complaint, and then there has to be a plan of correction and that type of thing. So on those revisit surveys, we caution hospitals to note that even though CMS or your accrediting organization may come back to revisit something that is specific, by all means be cautious. They do go into other areas as well, and they have the ability to do that. Sometimes in my past personal experience, have seen on a revisit survey where the surveyors then find something else, So a revisit survey is supposed to really be a specific area that they're looking at, but they can definitely expand that during that survey. A complaint survey, something we never want to have happen, but it does, is conducted after a complaint is filed. And sometimes, this allegation of non-compliance with either federal or state requirements, it will be unfounded. CMS will review these, the complaint, and say, okay, do we really even need to go on site? And sometimes they do. And then that can be, done by the state survey agency, or of course, the accrediting organization. I personally have been I know Christy has too, involved in complaint surveys in the past, and they're very uncomfortable. So having your staff always survey ready in the event that there is a complaint survey is a good thing to do. So again, this investigation into a complaint may or may not result in an on-site survey, but if so, then they will come in and they will survey. That typically directed at this, when they start asking for different documents and medical records and so forth, you can kind of get the idea of what this complaint was about, because they don't have to tell you, of course, beforehand. But then oftentimes they actually expand that into some other areas if they so choose. So for full surveys, our certification and validation surveys are always what we call full surveys. So they will then assess the organization's compliance with all the conditions of participation. And as I said, usually the complaint surveys and revisit surveys are more focused, but they can expand those if they so choose. So how does our surveyor prepare? And that's an important place to really start. So in the in the state operations manual, where these surveyors are trained, they are trained to look at, go ahead and prepare and look at certain things before they ever come on site. They're preparing their paperwork and getting all of their ducks in a row as well. So they'll look at what type of special features does the organization have? Are there swing beds? Do you have distinct part units, psychiatric rehabilitation? Do you have off-site locations? So if you happen to have a provider-based off-campus department or a remote location, then the survey team is required to assess compliance at the off-campus locations. If providing, if it's a same-day surgery, or it's a off-campus location that provides inpatient services like psychiatric or rehab, those are the things that they're definitely going to look at as well as, and of course, our swing beds. If none of the off-campus locations provide surgical or inpatient services, the surveyors select typically one off-campus location to survey as well. The surveyors will choose. That'll be up to them. They'll choose what off-site location they want to survey. They'll also look at prior application forms that have been sent in. They definitely, and we'll talk a little bit more about your previous survey results. They'll look at your previous survey results. They'll also review the plan of correction that was done. Christy and I were at a facility recently, and that's exactly what happened. They came right in. They had already reviewed that previous survey, and the surveyors focused head on for that original plan of correction that was done at the prior survey, and picked out those things that that the hospital had said in their plan of correction that they were going to focus on. So, they're already prepared for that. They look at licensure records. Another thing that has recently been discussed in great length is media reports, Facebook, any type of outside social media or external facing newsletters, document, anything that is publicly available, these surveyors will review as well. And we do know that unfortunately, if something happens or a patient's perspective on some treatment they received or a visit they had or a family member, that may show up on Facebook or in some complaint forum, and that's something that the surveyors can see. So make sure that we know what's out there on the web or any other social media about our organization. They'll also look at the organization's website. So what does your website say about the services that you offer the community, and is it up to date? Does it really explain what we offer, what we currently offer, and so forth? So make sure that we keep our organization, our website up to date with the current services and so forth that we offer at our organization. So the surveyors will prepare for observations. They make observations of the of care that's being given. Also, while they're touring the facility, they observe different things. They also planned for interviews because they will and can, conduct interviews with patients, staff, and sometimes patients, family members, and caregivers. And then they'll also prepare for record review. So they, review records that we maintain. Many times it's a certain amount of active records, closed records, and then, of course, policy and procedures as well. So, and this comes straight out of education that is on the QSEP site. If during a survey, a surveyor happens to notice a damaged blood pressure machine, during a brief interview with nursing staff, it's revealed that the machine malfunctions often and has been broken multiple times in the past few months, keeping the staff from using it. One nurse tells the surveyor that staff have submitted multiple requests for it to be fixed, but no one seems to be working on the issue. So given this particular situation, the surveyor would most likely ask for equipment maintenance records, stickers, the preventative maintenance stickers, a tracking system, what type of tracking system do we have for malfunctioning equipment and so forth. And, looking at your facilities maintenance request log. So those are things that we need to remember during a observation. This surveyor found this blood pressure machine. So if that's the case, what kind of documents are we going to ask for? And do we have all of those type of documents up to date and readily available? That's one of the really important pieces. So in this particular situation, during a survey, a surveyor decides to interview a patient regarding a fall. The interview could go something like this. So the surveyor may ask the patient, or make the statement that you fell out of bed on Wednesday. Is that correct? And then, of course, the patient, yes, that it is. And then the surveyor, using more of an open-ended question, would say, would you tell me a little more about how that happened? So given this particular situation, these surveyors use open-ended and closed-ended questions, and depending on what the surveyor finds during this conversation, the surveyor may ask for staffing records, call bell logs, fall risk policies, and any other, data and information that after this discussion may be valuable in understanding the causation of the fall and what was done after. So that's something else to consider. And this is the last of some of these examples. At the beginning of a surveyor reviews the facility's incident log and finds several reports of medication errors related to antibiotics. 2 of these were not caught in time and caused harm to the patients. So at the facility, the surveyor conducts interviews with the pharmacy staff and with staff who were involved in this patient care. During the interviews, the surveyor learns the pharmacy is using a new label and barcode system, but staff claim they weren't trained on how to read the new labels prior to implementation. So what do we think that the surveyor would ask for there? And it would be probably to review the med administration policies and the training records. Those are the kind of things that they may be sparked to look at. So now we're going to talk a little bit about what we call 2567 data. So I won't go into all of the different information there because you will have the slides, but basically 2567 data is available, like I said, publicly available data, and it's deficiency data for skilled nursing facilities, hospitals and critical access hospitals, so both PPS and critical access hospital. And the reason they call it 2567 is because that is the number that's associated with the form that the surveyors use when they conduct surveys. So when they're conducting surveys and they are evaluating our compliance with the conditions of participation, they create these the electronic versions of what we call the Form 2567, and that's where they associate their findings with specific conditions, standards, and then tags. So everything kind of marries together then. That's what you as a hospital then receive, is this report that the surveyors have prepared that tell you what their findings were, and they will be associated with what we call tags. And that can let you know, and the condition of participation that is related to. So that's what 2567 is. There are a couple of different citations that CMS can issue during these statement of deficiencies. One is considered a standard level deficiency, and that means that the hospital is out of compliance with one aspect of the regulation, but it's less severe than what we call condition level. Condition level means that the hospital is out of compliance with the entire condition, which can contain many different standards. The other level of non-compliance, which we never want to hear, is called immediate jeopardy. And that happens when surveyors have determined that the hospital has deviated from regulatory standards that can constitute an immediate threat to the patient's health and safety. So we don't ever want to hear immediate jeopardy. And I know I've received calls from hospitals that say, oh, they had received one and now what are we going to do? So that's something we don't ever want to receive because we can risk losing our termination for Medicare and Medicaid. So we want to keep everybody away from that. This is an example of a dashboard that our analyst has pulled together, and we do have a dashboard on our website too of this information, but he pulled from the 2567 data. So I like to look at this when if I was in a hospital and say, hey, and you can look at it too. Hospitals can go out to this publicly available data, and we encourage you to do so, and say, hey, you know, in my area, what are these top deficiencies? How many people are, you know, really seeing this particular deficiency? If you want to look at it, because it's in a huge spreadsheet form, and you can slice it and dice it, and the people who are really pivot tables can find all kinds, you know, pull the information in a different way. But right now, the information that is out there on the most recent link, the hospital deficiencies are showing through the end of September. I feel certain they'll probably update it at the end of the year. We'll be updating our website too. But I mean, that would be typical for them to do that. But right now, this is, you know, what the hospital deficiencies kind of look like. So we'll talk about some of the top 10 rural deficiencies, and I'm not going to get into some nitty, but I'll go through the way that this kind of looks on the within this 2567 information. You'll see the deficiency tag, and typically for our hospitals, critical access hospitals see a lot of the C tags, and then other rural hospitals, PPS hospitals, see A tags. K tags typically has to do with things like your maintenance. You know, it has to do with our environment of care and so forth. Fire drills, which are a lot. This just shows how many different hospitals had this particular K tag and how many deficiencies were related to that, and so forth and so on. Right now, I'm seeing across the country a huge increase in this. The compliance with 489.24, and I'll come back to that in just a minute. And that has to do with, for PPS hospitals, it's A2400, and for critical access hospitals, it's C2400. That has to do with compliance with some of the EMTALA regulations. So for instance, this first tag, it was K353 about the sprinkler system. So, and they write up all of this really interesting documentation about what this this tag actually means, and say that, you know, they observed or they found documentation or so forth that this is not, you know, up to par. So what they'll be looking for is, when is the last time the sprinkler system was checked? You know, what is that date? Who provided that test? Was it internal? Was it external? What is your water system supply source? So when you look at these different tags within the manuals, you can see what, you know, what the tag actually means. And then if we do have updated interpretive guidance for that and survey questions, you can see what the surveyors would be looking at. The next tag is, this is all about electrical systems. And so they're going to look for, again, different things about when it was checked, and making sure that your maintenance and testing of your generator and switches are being done the way that it's supposed to be done. This is another K tag that has to do with the hazardous areas, and making sure that everything is within the compliance guidelines there. Of course, infection prevention, surveillance, and control of hospital-acquired infections. This particular C tag relates to this particular condition of participation, but one of the standards. The tags for infection prevention, there are several, but these are just the most recent, you know, the top 10 most recently. Lots of fire drill tags that we've seen. Again, infection prevention and control policies, another standard. Maintenance is also in the top 10. Patient care policies also is in the top 10. Again, back to fire alarm systems and testing and maintenance. And then this compliance with 489.24, which is the special responsibilities of Medicare hospitals in emergency cases. So of course, EMTALA. There was a quote that I found during some of the research I was doing recently on EMTALA, and this Joint Commission specialist had made reference to the fact that, you know, this is something that that during a you know, surveys, sometimes it's just not on the radar. CMS finds a lot of facilities that have problems with EMTALA, and you as a facility are really responsible for ensuring that all of your, you know, EMTALA under this particular condition, everything, you know, you're checking all of the boxes. I recently looked at some data, and there seems to be a and I don't remember if this was in a specific region, but there seems to be a lot of focus right now as well on the emergency logs. So the logs within the emergency department that also fall under the compliance with this particular condition. So that's a an important one to remember. So just a couple of things to think about when it comes to EMTALA. So this particular hospital we called Hospital A, their particular EMTALA violation was failure to provide an adequate medical screening exam. And for most of the hospitals that I've seen that have received fines in the most recent past, that's typically associated with medical screening exams. This 35-year-old male with chest pain and shortness of breath presented to the ED, and he was accompanied by his girlfriend. The patient requested to see a physician and became belligerent when a nurse asked him why. That led to the patient then being escorted out of the ED by security. Several minutes later, the patient returned to the ED in the girlfriend's truck. She told the staff that he had had a seizure. She was informed by the staff that they would not help get the patient out of the truck. In addition, the security guard told her she had to leave. The patient's girlfriend then took him to another hospital where he was pronounced dead within 20 minutes of his arrival. So we can see how they received an EMTALA violation. Another one, Hospital B failed to stabilize an emergency medical condition. And this was a 58-year-old patient that presented to the ED for blurred vision and dizziness. And after failing to provide an appropriate emergency medical exam, an ED nurse directed the patient to a local eye doctor and failed to provide that medical treatment to stabilize the patient. This patient had a cerebral infarction. So of course they received an EMTALA violation. Another one, this was an off-duty volunteer at a hospital and had presented to the ER and told the desk that he was nauseated and thought he was gonna throw up. He was a volunteer, as I said. The ER was nearly empty. The wife and son continued to visit the triage desk, and over the next 2 hours, this gentleman lost his ability to speak or respond to questions. His breathing became labored. During a trip to the bathroom, his legs buckled, and then he needed support of his wife, and she yelled out, "I can't hold him up." She pounded on the wall, separating the bathroom from the triage desk, and no one came. So his son dialed 911 to see if they could take his dad to a different ER, and the operator told them that they couldn't pick him up at the ER and suggested that they get his dad to the parking lot so paramedics could pick him up. They did just that and took the man to the back seat of their car. The paramedics arrived, realized he was too sick to transport, took him back inside through the ambulance entrance, and the ER personnel started working on him. After an hour, they were performing CPR and the man died. So again, another EMTALA violation. So using data. So using data from the 2567 information for your specific state or region, that provides you some insight into some common areas of non-compliance, so you can prioritize those areas and, look at your own organization. Are we having trouble in that particular area? And helps you to be proactive to mitigate some of those deficiencies before a survey. And that will help you if you find that you have areas of non-compliance. You can train, focus your on those areas, and develop action plans so you can address these particular areas that you may find. So building your toolbox, we have kind of drilled this down to, or pared this down to 6 key tools. So utilizing your past survey and plan of correction, maintaining a document checklist, developing a revolving calendar of your policy reviews and revisions, conducting internal tracers, creating daily checklists for specific areas, and then design and print a pocket guide for staff. So we'll go through each of those. So utilizing your past survey, and I won't go through this entire example, but this is the regulation for this particular critical access hospital that we evaluated. And that was the standard that was not met. The surveyors then described why the standard was not met. And then the hospital had to create their own plan of correction. So when we came in, of course, we're going to go straight to that plan of correction. And we looked at the plan of correction to see then was what they said they would do, what this hospital said they would do in response to the finding, was it actually being done? So utilize your past survey plan of correction, go back to the past survey plan of correction and verify that in fact you are doing what you said you were going to do. We've been to many hospitals now, and without fail, with the plan of correction, it's very, we have found very, very few plan of correction items that have stayed, have passed the test. So that's a great place for you to go back to and look at to make sure that you are doing what you said you were going to do. Again, this is just another example of some other past survey plan of corrections. The next is maintain a document checklist and assign owners. So we know that the surveyors will ask for a lot of different documents, and typically there is, the standard list of what the surveyors are going to ask for. Well, let's have those ready. So let's divide, and this is just an example, let's divide these different documents into categories and assign an owner to each one of these categories so that we have everything up to date ready, whether you want that in a little basket, you want it in a box, you want it in a notebook, you want it electronically, however you want this information readily available. Divide it into categories and assign an owner to each category. So for an example, if you assigned meeting minutes and reports to one person, they may be responsible for collecting and having readily available med exec meeting minutes, your pharmacy and therapeutic meeting minutes, board meeting minutes, quality committee meeting minutes, fire drill documentation and evaluations, your infection prevention and antibiotic stewardship reports and meeting minutes, and so forth and so on. So think about all of the documents that you're going to have available for your state surveyor or your surveyor, and get all of those documents ready. Keep them ready. Have one person that is responsible for these areas that you have now divided different things into different categories, and have that one person or a team responsible for that. So we're not looking all over the organization to gather this information up when surveyors walk in the door. So maintain that document checklist and assign each area to owners. Develop a revolving calendar, possibly by month, for your policy and procedure reviews and revisions, and assign an owner. So divide into logical categories or departments. This is just my example. You can divide them in a way that works for you. And some people do have great policy manager programs, but many of the organizations we work with they do not have policy manager programs. So they really have to keep up with this themselves. So divide these different categories or departments into what we consider sort of logical areas, and then assign a month. So maybe in January, we're going to look at all the human resources, policies and procedures, and make sure we do our revisions and, review and revision. And maybe environment of care is in February. Nursing I have for June, maybe they need 2 months for their particular policy review and revision. But what seems logical to you, break it into these different categories and assign an owner of those categories. For example, maybe medication management is in May. And what does that entail? The policy on acceptable medication orders, medication administration processes and policies. How are we going to dispose of expired medications? Christy and I were at a hospital recently and we found a lot of expired medications and asked the staff, what are you going to do with that? Well, they didn't know, and they really didn't know where to go find it. So that's one of the reasons I put that one there. But, you know, just have a revolving calendar so that we're not waiting till one time of the year to do all of the policies and things get overwhelming and then don't get completed. Conducting internal tracers. Tracers are something that we have heard of for years, that were kind of born out of Joint Commission's methodology of, you know, targeting, having a targeted approach during the survey to really follow the path of a patient or the patient's care from start to finish, or for that patient's care in a specific area of time and place. So you can conduct your own internal tracers. Leadership can select monthly based on high risk areas, different things for you to accomplish a tracer on. Maybe it's something that's new and regulatory focused. Maybe it's you're going to start tracers on your old plan of correction. So if you had a plan of correction for a certain patient care item, maybe you develop a tracer for that. You create these teams, and hopefully your team members include a variety of multidisciplinary team members from all over. Bringing the staff in to be part of this team is a great opportunity as well, to really help the staff become more engaged and help promote accountability. Your team then will document their findings of this particular tracer, and then you all review these findings and develop actionable steps for any of the corrective actions that are needed. You can do internal tracers all year long, from different items that you find that are challenging for your organization. Creating a daily checklist and assign specific owners. This is very easy to accomplish as well. At your morning huddle, maybe you have what you call safety huddle or morning manager huddle. Assign different things off of your checklist, different areas and different things for people to check. Maybe it takes them 15 or 20 minutes that day to go in and check certain things. We use the example here, maybe assigning what we call medications and for this team member for this day, and this is their list. Check to make sure the medication room is locked if it's unsupervised. Look at the medication refrigerator to make sure that the thermometer is set appropriately. Do we have the medication refrigerator log complete? Make sure that there are no medications that are left unattended. Do we have any multi-dose files that are dated, that are dated with that 28-day expiration date? We shouldn't have any open single dose files. Do we have clean pill cutters and so forth? You get the idea. We have a checklist, and we're assigning at Daily Huddle something that individuals that are part of this can go back through that day, and we have it checked. We need to keep a continuous check, but this is a way to kind of organize that daily type checklist. And then finally, design and print a pocket guide for your staff. I find that pocket guides are very, very important. I had one at my home hospital, and we've had one hospital that we've been at that does use a pocket guide, and many others now that we've been with that are creating their pocket guide. This pocket guide just has organization specific information, and you keep it up to date. And as you get closer, it should be up to date, but as you get closer to your window, make sure that you update the things that that CMS is going to focus on, or your accrediting organization. Like, what are your quality measures and quality projects across the organization that you're focused on right now? I mean, our fire safety codes and information shouldn't change. All the emergency codes, different things like that never change. Our mission, vision, values, if we haven't changed those, and so forth. But potential survey questions. It's always good to also have included in your pocket guide, maybe on close to the last page, the people in our organization that you need to call for certain things. So we have it, the staff have it in their pocket, and it's readily available. It really gives them some confidence too, that they know how to answer some of these questions that may come up that they're not as familiar with during a survey, especially if they've never had to go through a survey. And I love this quote, failing to prepare is preparing to fail. So we need to prepare, and we need to stay survey ready so we can avoid the stress and the concern that we have when, and our staff will have when surveyors come in. And of course, it's unannounced in this situation, and that's a very, very scary and uncomfortable place to be. So that's always something to remember. We've included in our appendix a couple of different links for you. Again, as Cody said, we have questions, comments, that you may have, and we will open it up for that.
Oh, absolutely. Thank you so much for all the information. Yes. There are a couple questions that I will send to you separately, as they don't necessarily apply to the broad audience, but I will make sure you get those and get the answers to the people who have asked. I also got quite a few thank you for the information and people requesting the recording, which again, that will come out this afternoon. I hope. I've been having some issues with the computer, and sometimes it takes a little longer than normal, but hopefully that'll be out this afternoon. A couple questions to address right now. What are some common vulnerabilities rural facilities face during surveys, and how can they address them proactively?
Most of what we've seen is the lack of preparation, but not always because a hospital or staff members didn't want to prepare. We have, in rural hospitals, we tend to have a lot of turnover as well. And so we see that in many cases, the hospital has lost the historical knowledge. Say, for instance, that quality director that's been there for a while has left, and we have new people coming in that really don't and haven't been involved in surveys. So preparing the staff and preparing your team for survey is really a valuable thing to do, so that when that happens, we don't have these, oh, goodness gracious, let me go run in the closet type moment because I'm afraid that I'm going to be asked a question I don't know. Being prepared always sets you up for more success. So I think, ensuring that your staff feel comfortable, they understand where they can go to find the answers to the questions that they may have about specific conditions of participation, how to address certain conditions of participation. That really does set you up for a successful survey.
Okay, great, thank you. I'm gonna read, I've got one that just came in. I hope I don't mess this up, Victoria. If I do, let me know. With MEC being a big EMTALA violation, What are some suggestions for plan of corrections?
For the medical screening exam. So if you were to receive a medical screening exam, deficiency or MTALA violation, I would first review what policy that you're following at the current time. So, hospitals, this is the thing that's so interesting about the medical screening exam is it's based on your hospital policy and what your hospital bylaws and your medical staff have agreed to. So the medical screening exam is something that CMS always backs up with the information. They don't give us specifics about how things need to be done or what needs to be done, but they always like to go to the place of what is our patient population first? What type of patients do we typically see? And am I medically screening Carla the same way that I'm medically screening Christy? What does that look like? And is it in a timely fashion? And are we using best practice and national, professional organizations, national guidelines, but making sure that your policy covers who can medically screen and how that medical screening exam is going to be completed, and making sure that that medical screening exam is standardized, because we never want to have a violation or any concerns or deficiencies that are related to, I'm not screening Carla the same way that I'm screening Christy, because that can open up a huge can of worms and compliance issues. So I think that's pretty much where I would focus.
Great, thank you. And Victoria said thank you as well. What strategies can role leaders implement immediately to improve survey readiness?
First, I would convene your team. Know who your team members are going to be. Convene a survey readiness team, and then start with not only your state operations manual, but remember that you need to go to the electronic versions in the Federal Registry, because many organizations, and Christy and I have seen this firsthand, many organizations are just counting on the fact that their state operations manual is the Bible. And yeah, we like to think of it like that. But the state operations manual, I know for the critical access hospitals manual, hasn't been updated since February of February 21st of 2020. But there have been many other updates and changes to that manual, but they're not in the manual as you look at the SOM online. So we need to look at the electronic Federal Registry to make sure that we're looking at the right conditions of participation and standards. So create that team, have that team start with your last, immediately you can do this because you have your last survey plan of correction, and go to our state operations manual, whether that's for your PPS hospital, your critical access hospital. Look at that state operations manual and then get the updates out of the electronic version so that we stay on top of things on a daily basis.
Okay, thank you. We are at 2 minutes till, and I don't have any questions at this time, although I did see a couple people typing. Please don't hesitate to reach out with those questions. You can send them directly to the team, or you can send them to me and I'll make sure that they get passed on. Carla, I'm going to turn it back over to you for some closing remarks before I end us for today.
Absolutely. Thank you so much for joining us. Our survey readiness team always here to answer questions. myself, Christy, Cameron, and Keith is our analyst. We're here if you ever need us for anything. Again, if you do, as Cody said, think of any other questions, please do not hesitate to send them on, and we'll get right back with you on that.
Great. Thank you so much, Carla.
Thank you.
Chris. I know she's with us today and having a little bit of sore throat like I am. Everyone, thank you for joining us today. We do hope this session gave you new insights and some ideas to take back to your team. As a reminder, a recording will be sent to you later today, or you can revisit anything so that you could revisit anything you found especially helpful. Before you go, remember, we would love to hear from you. If you could just complete that brief survey, we do use that to keep these sessions relevant and impactful. Also, if you're looking for additional ways to grow your leadership skills or expand your impact, please go ahead and visit NRHASC.com for more educational resources. And if you'd like to learn more about our leadership development programs or discuss how they could benefit you, please feel free to reach out to me, and I'm happy to discuss those options with you. We're always happy to help. Again, have a great day, and we look forward to seeing you next time. Thank you, everyone.